Yeah. This is just you need to read interpretation of the lateral view. So what are you going to check for adequacy, the alignment, the bones, the cartilage, and the soft tissues, okay? Plain films of the C spine are not reliable in the patient with a significant trauma, should be used with a caution. So it's very important. Sequel of the C spine fractures, acute and the chronic one, how it presents. Spinal shock, what are the signs of spinal shock? Okay. So decreased reflexes, no sensation, flaccid paralysis below the level of injury, lasting days to months. So in these cases, we don't go for treatments because in that cases, we just call the cervical surgeon, a cervical surgeon, or the head trauma surgeon, or whoever is present in emergency at that time. So we call them and then they follow them with that. Our duty is just to order, stabilize the patient, like maybe ABC, like breathing and all that, and then CT scan. So by the time they do the CT scan, the head surgeon or the spinal surgery surgeon, like sorry, spinal surgeon, they usually come there. So they will follow up from there. Then decreased reflexes, neurological shock, loss of the vasomotor CNS tone, watch for the hypotension, bradycardia, poikilothermia, like lacking CNS or the shutting of the blood from extremities to the core, occur within 30 minutes. So it's very important you know what are the signs of it, okay? Occur within 30 minutes, the neurogenic shock occurs within 30 minutes of spinal cord injury at level of T6 or above. This is very important. Which level? Lasting up to 6 weeks, provide the airway support, fluid, and atropine. So this is our duty to do it until the spinal surgeon comes. Chronic phase of the spinal cord injury, although we don't watch for this one, but sometimes what happens is we are given a case where the patient already had a spinal cord injury, and now we are just following up because he has some bladder distension or bowel distension is going on. So in that cases, we are just doing DRE or passing a Foley's catheter. So this is also done in emergency department. So this is basically monitoring or stabilizing a patient who has already been admitted in the hospital and come to the emergency for further intervention, or was in home care and now coming to you as an further intervention. Hope that makes sense. So that's how we are going to deal. This is not like a acute case that presents. So in those cases, what are those ones? Pounding headache, nasal congestion, feeling of apprehension, anxiety, visual changes, dangerous increase systolic and diastolic blood pressure. Common triggers are gastrourinary and sorry, genitourinary and gastrointestinal. So in those ones, the kidney stones, distension, infection, the fecal infection, so those ones. So monitoring and controlling BP and addressing the causative agent. So you as a family physician are going to be stabilizing that patient and sending back where he comes from. Then chest trauma, the airway obstruction, tension, pneumothorax, very, very important. See the x-rays. How does the x-ray look like? Then how does they present? And what kind of injury? Emergency medicine, especially traumatology, all about injury. Airway obstruction, basically checking for anxiety, stridor. Stridor is one of the very important factor that shows the airway obstruction, hoarseness, altered mental status, apnea, and cyanosis. Do not wait for ABGs. Although we send for ABGs, but we don't wait for it. Definitive airway management, like intubate early if present, remove foreign body with McGill for forceps. So there's a forceps that we do. Provide to the intubation, be prepared for a potential surgical airway. Then tension pneumothorax, clinical diagnosis. So one way valve causing accumulation of the air. So that's why we go for the needle thoracotomy. So how does it present? So basically there is asymmetry of the chest wall motion and there is no radiograph diagnosis. So in this case, the tension pneumothorax, we just do the assessment. Don't go for any investigation. Let's suppose if they ask for given a scenario of tension pneumothorax and you are able to make a diagnosis and now this says what is the investigation you would like to do. Don't write x-ray. It's basically they're asking you if are you aware of doing it or not. So we are not going to, you have to be very confident when you are writing none. Okay, so it means they're asking you, are you going to do or use the Canadian resources as it is, or you know where you need to use it. Okay, so in tension pneumothorax, we don't do any kind of like investigations. You have to make the diagnosis through your examination. Then comes to the open pneumothorax, gunshot wound or other wounds, equal breath sound. So we do ABGs, air tight dressing, three side and chest tube and surgery. Massive pneumothorax, go for pallor, unilateral breath sounds, absent breath sounds, hypotension, unilateral dullness. So we go for X-ray. entire lungs appears radio opaque, so you need to see the X-ray, very important. Then restore the blood volume, chest tube thoracotomy if there is more than 1500. So they can ask you in MCQs, when are you going to do the thoracotomy? Flail chest is basically fresh floating segment of the chest wall due to more than 2 rib broken. So in that case, is what happens is paradoxical movement of the flail chest, palpable crepitus, and decreased airway. So what are you going to do? Venous blood gases. And the same time, CT scan. Oxygen fluid, pain control, that's it. So in that cases, we don't need to do anything if there is not a very significant deterioration going on. Then cardiac tamponade is basically a clinical diagnosis. They write it down here, the clinical diagnosis. In that case, we are not going to do echo, fast, nothing at all. This is basically clinical diagnosis. Pericardial fluid accumulation. So we are going to check for Beck's triad. So IV fluid, open thoracotomy. Even if this is a clinical diagnosis and you do any investigation, especially in emergency department, you will get 0. So spine oblique views, rarely used, better visualization of the posterior element fractures, good to assess the patency of the neural foramina, can be used to visualize the C7 to T1 junction. 20% of the C spines are accumulated by their other spine fractures. So ensure the thoracic and the lumbar spine CT is normal before proceeding to OR, operative room. Then trauma to the chest is basically accounts for 50% of the trauma deaths. 80% of all the chest wound can be managed non-surgically. So as we said, this is all open and flail, they can be chest. So 3-valve method, you can see how does it work. Then the pulsus paradox is a drop in the BP of more than 10 is basically recall that the BP falls with its inspiration. So now coming to the pulmonary contusion, this is basically, as you can see, this was from primary survey. This cases presents, or you can assess them in secondary survey. Okay, so pulmonary contusion, so blunt trauma to chest. So you are going to find out in the secondary survey, although it's very life-threatening. CT scan you do, maintain the adequate airway, breathing circulation, and then causing for physiotherapy and ECG and all that. Ruptured diaphragm where the lungs come into the like in the abdomen. So blunt trauma can be the cause of it, abnormality of the diaphragm. So in that case, is you do the laparotomy and do fix the intra-abdominal, like the diaphragm. Then the esophageal injury. Then, this laparotomy is not going to be done by us, but they usually ask for treatment anyway. Esophageal injury, usually penetrating trauma. It's basically the mediastinal air is going inside that one. And which test are you going to do? Esophagogram, early repair. It's also common. Aortic tear is basically 90% of the tears at the subclavian. Okay, most die at the scene. So it's very unusual that someone reached to the emergency, but let's suppose someone reached and we do thoracotomy right away and do chest X-ray, CT and all that. Blunt myocardial injury, blunt trauma to the chest. So leading towards the overlying injuries, basically the trachea, the chest wall and all that. So we're going to do the ECG, monitoring the heart is important. And what are we going to do is giving oxygen. Ruptured diaphragm is more often diagnosed on the left side as the liver conceals the right side. Aortic tear, though, in the aortic tear, what are you going to see is basically ABC, white. So X-ray, you will see the aortic tear, then depressed left main stem, bronchus, then pleural cap, wide mediastinum, hemothorax, and distinct and tracheal deviation and esophagus. Penetrating neck trauma. So in the penetrating neck trauma, so all the 3 zones, very important. All these 3 zones, you need to see which one is up to which level and which one is up to which level, okay? I mean, they might ask you in MCQs, but it's very common in neck or skin. So then coming back to this one, how are you going to manage? So basically the platysma is basically the one that's broken and requiring by angiography if there is any, vein or vessel is broken, because on the basis of the level or the zone, you can see which artery or which vein could be damaged. Okay. If penetrating neck trauma present, don't clamp the structures, probe, insert, don't insert the NG tube. Remove or don't remove the weapons. Do not explore the penetrating neck until the patient is in the operating room. Then airway injuries always maintain a high index of suspicious that there is a problem going on. So that's why you have to always check for the larynx and the trachea. In the larynx, how are you going to see? What are you going to see? The triad is basically hoarseness, emphysema, and palpable fracture. And other is hemoptysis, dyspnea, dysphonia. What are you going to do? Chest X-ray, CT, and angiography. And sorry, arteriography. We usually stop at CT scan. We don't go for arteriography. Airway, C-spine, and surgery. So airway is important, checking for edema. C-spine, so in that cases, if you feel suspicious of the patient might develop edema later on, in that case, you can do intubation right away. Like especially in the burn cases, in poisoning cases, like that. Then trachea, frequent miss. So it's very common that people do miss this one. Deceleration, penetrating, increase the intrathoracic pressure, complaints of dyspnea and hemoptysis. So you do chest X-ray, mediastinal air, persistent pneumothorax and persistent air leak from the chest tube inserted for the pneumothorax. So in that case, you do the surgical repair if more than 1/3 of the circumference. Do look for which artery or which vein is more close to skin in which zone. Okay, I hope that makes sense. Like jugular vein or the carotid artery, I think it's in the zone 3 or 2 or something like that. So where it is very close. So you have to see. So you, according to that, you need to see which injury is happening and what structure. So you have to visualize in your brain that which structure could be the most affected in that part and what should be my first goal to treat or look for in any kind of the case. Abdominal trauma, two type, blunt and penetrating, as we already discussed. The most common is spleen and the second most common is liver. Blunt trauma is basically two type of hemorrhage, intraperitoneal and the retroperitoneal. Adopt the high clinical suspicious of the bleeding. So starting with the same mechanism of injury and then sample, asking for all the questions. Then you're going to do a physical examination and investigation. Now you will slowly see that there is less amount of management. What are we going to do? But we will discuss. I will let you know what I'm talking about. So physical examination, you are going to do the slow blood loss, not immediate apparent, tachycardia, tachypnea, oliguria. So this one is basically, yeah, blunt trauma of the abdomen. Hypotension, other injuries may mask the symptoms. Serious examinations are required. So you are going to start with inspection, inspection, auscultation, palpation, and DRE. So in that case, we are going to start with this one. Inspection, looking, what are you going to see? They do ask in the questions in the inspection, what are you looking for? Then the options they give you, this is this, this is this, this is this. So contusion, abrasion, seat belt, and distension. Then auscultation, what are you looking for? Very important is bowel sounds. We do check for bruit as well. Then the palpate, so tenderness, rebound tenderness, rigidity, guarding, any sorts of, like leaking present in the abdomen. Then DRE, very important if there is blood or bone fragmentation or prostate location. Then the placement of NG and Foley's catheter should be placed after the abdominal examination. Then other systems like cardiovascular, respiratory, depending on which it is more damage. Seat belt injuries may occur in the retroperitoneal duodenal trauma. What kind of injuries they can be? Mesenteric injury is very, very important. L-spine, like very common, intraperitoneal bowel transaction and L-spine. So then this is indication of the Foley's and then NG tube. When are you going to put on that one? Foley's is basically unconscious where you feel like he has multiple injuries. So in that case, we're going to put the Foley's just to check the urine output. In NG tube, we're going to do the decompression of the stomach. So in all kind of abdominal cases, regardless of finding out if there is any injury to the face, then we go for NG tube. So after ruling out the like NG's NG tube contraindication, then we go for NG tube placement. Then CBC, electrolytes, coagulation, cross and type, glucose, creatinine, CK, lipase, and amylase is very important in abdomen because we are checking for the pancreas and liver and all that, and especially the lactate as well. We check lactate as well. Then liver enzymes, venous blood gases, blood alcohol level, beta HCG, very important, especially in the female. Don't forget the beta HCG. Urine examination and then toxicology screen. Okay. Then comes the imaging. Fast is something that we do for every cases, especially if you feel like this is basically needed to be done within 5 minutes. It's a rapid examination. We do like there is a lot of false positive, but it's a very safe one and do it very right away. So then X-ray, checking for the chest, soft tissues not visualized. CT scan, most common specific test, like especially even the appendix, they go for CT scan. Although I don't know why, but CT scan is one of the most authentic one. Then diagnostic peritoneal lavage, then most sensitive test cannot test for the retroperitoneal bleed or the diaphragmatic rupture, cannot distinguish lethal from the trivial bleed. Results can take up to 1 hour. So the most fast is fast. Imaging must be done if equivocal abdominal examination, unexplained shock, patients have a multiple trauma and must undergo general anesthesia for orthopedics, fracture for the lower ribs, pelvis, and spine, then positive fast. So in that cases, then comes the management. What are you going to start with? ABC, you as a emergency medicine. ABC, early blood product stabilization. Then surgery is basically waiting, especially in the cases of abdominal pain. In that case, is distension, looking for, how far it can go and then waiting for that one and then go for laparotomy. Solid organ injuries, decision making on the hemodynamic instability, not the specific injuries. Hemodynamic unstable or persistent, high transfusion requirement. So basically laparotomy. Hollow organ injuries, we go for laparotomy. So if low suspicion, so basically you don't need to go into very detail. You just need to know in which cases where laparotomy is basically calling for a surgeon. So you need to know like when are you going to do a laparotomy, because this is up your call. When are you going to call the surgeon? Let's suppose if the patient got stabilized later on and you did not do watchful waiting, you called surgeon, you got panic. In that cases, now you are a dangerous doctor. So you need to see when are you going to make a decision of laparotomy and call the surgeon. Although you're not going to do laparotomy, but you need to know when it's the time to do it. Then penetrating trauma. So high risk of the gastrointestinal perforation and sepsis. History, size of the blade, caliber, depending on which one it is. So local wound exploration under direct vision may determine the lack of peritoneal penetration. Thoracoabdominal region, back or flanks, muscle too thick. So then in those cases, we're going to do ABC, fluid resuscitation, stabilization, gunshot wound, always require the laparotomy. Then on the side, when is laparotomy mandatory? So as you can see, this is what you need to know. Shock, peritonitis, evisceration, free air in the abdomen, blood in the engine means there is something going on inside and you want to do the laparotomy, checking out if there is any splenic artery or something that is damaged that needs to be done, surgery right away. Rule of the thirds for the stab wound, 1/3 do not penetrate the peritoneal cavity, 1/3 penetrate but are harmless, 1/3 cause the injury requiring the surgery. Then comes the genitourinary. So let's finish the genitourinary. And after that, I would like to go to, in the next class, I would like to go to general surgery. I would like to do some topics, like cover some topics from there. Then we come back to orthopedic and then we will do orthopedic from orthopedic chapter. Okay. Hope that makes sense. So I'm trying to make them all together so you have an idea what we are doing. Then genitourinary tract injuries, blunt injuries, often associated with the pelvic fractures, upper tract renal contusion. Non-communicating and communicating could be depending on the laceration. Ureters could be there. That is very, very rare, but yeah, it is there. Lower tract, which is including the bladder and the urethra. So that the penetrating trauma, acceleration, deceleration injuries, and iatrogenic. Okay, so we don't, for the genitourinary, we don't order CT abdomen. We order, sorry. So for genitourinary, we order CTKUB. So you need to write down the right word. If you write abdomen, it's going to be incorrect. Although abdomen covers KUB, but when it comes to kidneys, you have to write down CTKUB. Writing abdomen is wrong. Mechanism of injury, hematuria, blood on the underwears, dysuria, urinary retention, history of hypotension. Then coming to a physical examination, doing flank pain, tenderness, CVA, costovertebral tenderness, upper quadrant, and perineal laceration. DRE, checking for all that. Scrotum, checking for laceration and Testicular cremasteric reflex, don't forget that one. Bimanual examination, speculum examination you do, and then the extraperitoneal bladder rupture, if there is anything extrapubic tenderness and all that, intraperitoneal bladder rupture, so acute abdomen, and then the urethral injury, so peritoneal ligaments. So it depends on what you are looking for. So they can ask you how you are going to check for the suprapubic tenderness or what can the suprapubic tenderness show. Okay, so in that case, it shows the extraperitoneal bladder rupture. Investigations, what are you going to do based on which structure is damaged? As I told you, you need to see what they are given in the questions. That's why I try to do a lot of questions, like, from UWord or whichever bank you are using. Urethra, retrograde ureterogram, bladder, then CT scan, urine analysis, CT scan, ureterogram, we go cystoscopy, cystogram. This is basically done by some urologist. We don't go for that much. We just go for urine analysis, urine culture and sensitivity, urine cytology. So these are the things. Then ureter, for that one, retrograde ureterogram. Then renal CT scan. Urology consultation. If you find out there's something going on, then urology consultation. So your gross hematuria suggests the bladder injury. So renal, basically minor injuries. In those cases, only the conservative management, that hydration, analgesics, antibiotics, those ones. For the major conservative management with serial urine analysis, then surgical repair, basically hemodynamically unstable or continuing to bleed more than 48 hours, major urine excavation, injury, all excavating. So in those cases, we'll check for whatever is going on. Then ureter, we do the ureterostomy. Okay, so from one ureter, you attach the other ureter. Bladder is basically extraperitoneal, the minor and the major. Minor is basically Foley's drainage. We put and then take it out. Then the major rupture is basically surgical repair, intraperitoneal. So with the Foley's catheter, what kind of complications can cause, and what are the, I think there's a question for the Foley's catheter. What are the complications or what are the side effects? Something like this for the Foley's catheter, even for the NG tube if it's placed for more than some time. So it can cause infection, it can cause a lot of like distension. So please look onto those ones too. Then extraperitoneal, intraperitoneal, then comes to the urethra. So in urethra, it's basically conservative if cannot void Foley's or suprapubic cystotomy and antibiotics. So sometimes they ask you if you cannot place the Foley's catheter and then you need to drain. What are you going to do? So basically suprapubic cystostomy. Then the posterior, you do suprapubic cystotomy and surgical repair. In case of the gross hematuria, the genitourinary system is investigated from distal to proximal. So we do cover this much. There is a lot more. But after this, I will start the surgery. And from there, we will do the acute abdominal pain. And we'll try to cover the abdomen from there. Okay? I will let you know what to do. You need to do from there. If there is anything extra, then I will also let you know that what I'm not covering. Okay? I think that's about it for today's class. If there is any question, please do let me know. And sorry.